All right, so this chapter is a connect the dots chapter, and I'm going to break it up into several videos to keep them nice, neat, and short. Our first topic is going to be the body fluids and fluid compartments. Since this is all about balance, balance suggests a state of equilibrium where whatever we're discussing, the amount that comes into the body is going to equal the amount that leaves. When we talk about water, water and electrolytes are always tied together because electrolytes are dissolved in the water. There's going to be mechanisms to replace things that are lost when we're talking about water and electrolytes, and mechanisms to excrete anything we have in excess. Homeostasis just means everything stays the same regardless of what we do. We want to maintain that constant internal environment. And we've been looking at this picture about how water always follows salt. So due to their nature, we're going to discuss both water and salt together. All of physiology is going to occur in an aqueous environment. That means water is our solvent, and the electrolytes or ions are going to be dissolved in the water. So we have water as our solvent, solutes, anything dissolved, so sodium, chloride, potassium, they are in solution. Proteins are more suspended in solution, but they count too, so we'll be discussing proteins. And we say that water follows salt, but it will also follow any other electrolyte. As far as body water content, that varies based on age, on sex, on muscle to fat ratio, and bone density. So when a baby is born, they are about 75% water. We come into the world all soft and squishy, and then as a person ages, we're in a slow, steady state of desiccation. We're just slowly drying out. So if a person makes it to old age, they're going to be about 45% of water. The difference between the biological sexes has a lot to do with the sex hormones and the percentage of muscle mass versus fat tissue. If you look over here, different tissues have different amounts of water. The brain, the kidneys are really high amounts of water, so 80 to 85%. Muscle mass has a high amount of water, so 70 to 75%. But adipose tissue, so fat is hydrophobic, it doesn't have a lot of water associated with it. So in general, males have a higher amount of water content at 60%, and in general, females have less water content at 50%. So if we just want to say overall adult humans, it's 55%. That's just a nice round number. All right, play along with me. So when we are born, we have our highest water content out of the whole span of our life. We slowly desiccate and dry out as we age. So the highest water content is going to be that baby. The lowest water content is going to be the 54-year-old woman. Next, the two biological sexes, men typically have a higher water content than women. As far as where this fluid is located in the body, we divide it up into two fluid compartments. The majority of water is going to be inside of cells, so they call that the intracellular fluid compartment, or ICF. So 60% of the water content in the human body is going to be inside of cells. That means the other 40% is going to be in the extracellular fluids, and extracellular fluids, the majority of that is going to be what's called interstitial fluid or tissue fluid, so the fluid between the body cells. Also, what's included in that extracellular fluid compartment is plasma, the fluid portion of blood. And then we have these other fluids called transcellular fluids. Think of synovial fluid or vitreous humor or serous fluid. So we have some other fluids in the body. So they're also contained in that extracellular fluid compartment. The distribution of ions and proteins is going to be different in those two body compartments. If we look at this graph over here, we'll look at the extracellular fluid compartment first, which is going to be the blue and the red bars. And you can see that in the extracellular fluid compartment, sodium is by far the highest concentrated ion in the extracellular fluid compartment. Next, sodium's friend is always chloride. So you have more chloride in the extracellular fluid compartment. And we are going to discuss bicarbonate. We learned that bicarbonate, we like bicarb, it's our base. It helps us buffer the acids that we make. So we have more bicarbonate outside of our cells than inside of our cells. And the other one I want to draw your attention to is calcium. And I realize that graph sort of shows that there's more of it intracellularly, but when we discuss electrolyte imbalances, I'm going to tell you that there's more free calcium outside of the cells than intracellular, because inside of cells, calcium is normally locked up in endoplasmic reticulum, or in the case of muscle cells, it's going to be inside that sarcoplasmic reticulum. So free calcium is going to be higher outside of cells in the extracellular fluid compartment. If we look at the intracellular fluid compartment, so these pale bars, what a weird color to choose, we see that potassium is highest inside of cells. The next ions that we see are phosphate. Whether it is monohydrogen phosphate or dihydrogen phosphate, the majority of that is going to be inside of cells as opposed to outside of cells. Magnesium is also higher inside of cells than outside of the cells. And there's more proteins intracellularly than extracellularly. So things are going to be balanced from outside of the cell to inside of the cell, but they're not necessarily the same in composition. This distribution of ions, we have more sodium ions in the extracellular fluid compartment than the intracellular fluid compartment, and more potassium ions inside. Our cells constantly expend energy to make sure we have that resting membrane potential, and that's due to the sodium-potassium pump. So we use ATP to continually pump out 3 sodium ions to this extracellular fluid compartment, and we bring in 2 potassium ions to the intracellular fluid compartment. And that's why all of your cells are charged. Only neurons and muscle cells are excitable, but all the cells are still constantly working to maintain this distribution of ions. Sodium ions account for almost 90% of the positively charged ions in the extracellular fluid compartment, and that is why we can say, because it's the most abundant, that's why water always follows sodium. So water follows salt. The potassium inside of cells is going to be incredibly important for maintaining resting membrane potential, because we're going to move into electrolyte imbalances, and we're just going to sum it up. Electrolyte imbalances are going to affect neurofunctioning and muscular functioning, because it changes that distribution of ions. So if you are a picture person, this is a great picture for you. It's showing you that the majority of water is going to be intracellular, 60%, extracellular is 40%, and that major distribution of ions that I want you to know is that intracellular, that's where most of the potassium is, that's where most of the phosphate, we're going to use that as our buffer, and then protein buffers are, we have them both intracellular and extracellularly, but it can be super powerful inside of cells, particularly red blood cells. Extracellular, high amounts of sodium, bicarbonate, we're going to use that one as our buffer. Right, so most water in the human body is going to be found inside of cells. You also could tell that from this question, because plasma is actually part of that extracellular fluid component. All right, how about this one? Most potassium is found where? Oh, we've got potassium everywhere. All right. Most of it is going to be inside of the cells. Potassium, I want you to equate that with setting the resting membrane potential of a cell. More sodium is outside, we've got more potassium inside. That difference in electrolyte concentration is maintained by the sodium-potassium pump. Next unit, we're going to get into what's called your basal metabolic rate. That is how much energy your body consumes just at rest. Part of that energy is going to maintaining this electrolyte distribution. The most abundant cation in the extracellular fluid is Cation is a positively charged ion. There's more sodium outside of cells than inside of cells, and sodium accounts for about 85 to 90% of the osmotic pressure. So there's way more outside, so it is the most abundant, that just means most concentrated electrolyte, positively charged outside of cells. If we look at this picture, remember when we discussed the cardiovascular system, we said on that arterial side, we have that net hydrostatic pressure forcing fluid out on that arterial end, and then we have osmotic pressure drawing it in on that venule side. Once there's fluid in this interstitial space in between tissue cells, water just moves by osmosis, and it's always going to move to a state of equilibrium. We can't stop water from moving. It just does. We know that the lymphatic system is going to pick up excess interstitial fluid when that pressure builds, those little doors of the lymphatic capillaries open and fluid rushes in. But the fluid's also going to move inside of the cells. And transcellular fluid, like I said, those are all the other fluids we haven't discussed. So not tissue fluid, not plasma fluid, any of the other fluids we have. And it's just going to move always in a state of equilibrium. So what this means is if we lose fluids in one compartment, there's going to be a loss in fluids in the other compartment. Take, for example, if somebody gets dehydrated, they're going to be losing fluid first from that interstitial fluid, from the tissue fluid, because that's where the sweat's going to come from. Then water will equilibrate and move out from the plasma, and we're also going to lose fluid from the intracellular fluid. So when someone dehydrates, they lose blood volume, they're going to lose blood pressure. Their cells will also lose water as well. So just think of all of these spaces. As far as water is concerned, water will just always move between these compartments. We can't stop that from happening. That is true. That's the point I'm trying to make. If you lose fluid anywhere, however you lose it, there's going to be a loss over the entire body. From extracellular fluid, intracellular fluid, it's always going to equilibrate. So you'll particularly have to worry if any of those conditions with your patients, excessive sweating, vomiting, diarrhea, is a loss of fluids. You're going to see that in a drop in blood volume, and we've connected that already. We know that lowers blood pressure. They're disorders of this fluid balance. Edema is excess fluid in this interstitial space. So it's excess tissue fluid. Ways you get edema or swelling, we learned about inflammation when we discussed the immune system, first response to injury or infection. Lymphedema is when there is a blockage in lymphatic vessels, so it's not being picked up and returned to the cardiovascular system. There's specific types of edema. Pulmonary edema is swelling in the lungs. Peripheral edema is swelling usually in the tissues. You normally see it in the extremities, so in the limbs. We talked about congestive heart failure. So left side heart failure, you get pulmonary edema. Right side heart failure, you get peripheral edema. And liver disease, the liver is responsible for making those albumins that pull the fluid back on that venule side, and if they're not there, there's going to be edema and swelling. Water balance means the amount of water coming into the body equals the amount of water leaving the body. Roughly, this is about 2.5 liters per day. 2.5 liters is 2,500 milliliters. Homeostasis is going to require those to be balanced. Where we get the majority of our water is through taking in fluids, so beverages. We get water also from the foods that we eat, and 10% of our water comes from that water of metabolism, so through our cellular respiration we make water. So 60% from fluids, from beverages, 30% from foods, and then 10% that water of metabolism. How we lose our water, number one, is going to be through urine output, so about 60%. There's something called insensible loss. That is loss of water that we're not aware of. That's what it means by insensible. So even though up here, I don't feel like I'm sweating. I'm sweating a little bit, so are you. When we speak, you know that when you exhale, water comes. That's why you can clean your glasses or clean your phone screen by blowing on it. So that's what's meant by insensible loss. Sweating due to heat, like you know when you're overheated, you know when you're sweating. So that's 8%. And then of course there's some fluid in feces, so about 4% in feces. Balance means that the amount coming in is going to equal the amount going out. Right, majority of it is going to be lost through urine. We learn about 60% that way. We're going to lose about 28% that we're not even aware of. We're going to lose about 8% to sweat and 4% through feces. All right, what would happen if we didn't drink water?
Water is virtually everywhere, from soil moisture and ice caps to the cells inside our own bodies. Depending on factors like location, fat index, age, and sex, the average human is between 55 and 60% water. At birth, human babies are even wetter. Being 75% water, they are swimmingly similar to fish. But their water composition drops to 65% by their first birthday. So what role does water play in our bodies? And how much do we actually need to drink to stay healthy? The H2O in our bodies works to cushion and lubricate joints, regulate temperature, and to nourish the brain and spinal cord. Water isn't only in our blood. An adult's brain and heart are almost 3/4 water. That's roughly equivalent to the amount of moisture in a banana. Lungs are more similar to an apple at 83%, and even seemingly dry human bones are 31% water. If we are essentially made of water and surrounded by water, why do we still need to drink so much? Well, each day we lose 2 to 3 liters through our sweat, urine, and bowel movements, and even just from breathing. While these functions are essential to our survival, we need to compensate for the fluid loss. Maintaining a balanced water level is essential to avoid dehydration or overhydration, both of which can have devastating effects on overall health. At first detection of low water levels, sensory receptors in the brain's hypothalamus signal the release of antidiuretic hormone. When it reaches the kidneys, it creates aquaporins, special channels that enable blood to absorb and retain more water, leading to concentrated dark urine. Increased dehydration can cause notable drops in energy, mood, skin moisture, and blood pressure, as well as signs of cognitive impairment. A dehydrated brain works harder to accomplish the same amount as a normal brain, and it even temporarily shrinks because of its lack of water. Overhydration, or hyponatremia, is usually caused by overconsumption of water in a short amount of time. Athletes are often the victims of overhydration because of complications in regulating water levels in extreme physical conditions. Whereas the dehydrated brain amps up the production of antidiuretic hormone, the overhydrated brain slows or even stops releasing it into the blood. Sodium electrolytes in the body become diluted, causing cells to swell. In severe cases, the kidneys can't keep up with the resulting volumes of dilute urine. Water intoxication then occurs, possibly causing headache, vomiting, and in rare instances, seizures or death. But that's a pretty extreme situation. On a normal day-to-day basis, maintaining a well-hydrated system is easy to manage for those of us fortunate enough to have access to clean drinking water. For a long time, conventional wisdom said that we should drink 8 glasses a day. That estimate has since been fine-tuned. Now the consensus is that the amount of water we need to imbibe depends largely on our weight and environment. The recommended daily intake varies from between 2.5 to 3.7 liters of water for men and about 2 to 2.7 liters for women, a range that is pushed up or down if we are healthy, active, old, or overheating. While water is the healthiest hydrator, other beverages, even those with caffeine like coffee or tea, replenish fluids as well. And water within food makes up about 1/5 of our daily H2O intake. Fruits and vegetables like strawberries, cucumbers, and even broccoli are over 90% water, and can supplement liquid intake while providing valuable nutrients and fiber. Drinking well might also have various long-term benefits. Studies have shown that optimal hydration can lower the chance of stroke, help manage diabetes, and potentially reduce the risk of certain types of cancer. No matter what, getting the right amount of liquid makes a world of difference in how you'll feel, think, and function day to day.
So regulation of water intake is controlled by our captain, the hypothalamus. The hypothalamus has osmoreceptors, so they can detect plasma osmolality, and that really reflects the state of hydration. And I wore my shirt today, it says, "Why so salty?" And think of osmolality like that. It's the ratio of solutes of water, solutes to water in plasma. So if there's a high osmolality, that means we become salty. That represents a low state of hydration, low amount of water. If we're not salty, that means there's more water and less salt, and we're hydrated. So if there's insufficient water in the body, that is going to increase that blood osmolality. The osmoreceptors in the hypothalamus are going to pick that up. We also know that just because our mouth also gets dry, that will also send a signal to our thirst center, which is the hypothalamus, and that's going to drive us to seek water. So that's really what thirst is. It's just a drive to seek water. Angiotensin II from our renin, angiotensin, aldosterone system also stimulates our thirst. The other thing we get when we are salty and there's an increase in osmolality detected by the hypothalamus is that release of antidiuretic hormone, ADH. Remember, the hypothalamus makes it, sends it to the posterior pituitary, our storage shed, sends a neural stimulus to the posterior pituitary, and releases antidiuretic hormone. The two targets for antidiuretic hormone, one, its other name is vasopressin. So we get constriction of our arterioles and our vessels, which is going to increase blood pressure. The other target is the kidneys. What effect it's going to have on the kidneys is to cause aquaporins, those doorways for water, to be placed in the collecting ducts, and this will facilitate movement of water from the lumen in the tubules through the collecting duct cells, and then also aquaporins on that basolateral side, so then it will move to go back into plasma. It is going to reduce urine volume and increase urine concentration, so someone will have a lower volume, higher concentrated urine, so it's going to have a higher specific gravity. We looked at that when we did urine analysis. Antidiuretic hormone, antidiuresis, so anti-urination. So we're going to have to reabsorb water from the filtrate back into the bloodstream. We're trying to increase blood volume. Yes, our captain, the hypothalamus, that is where the thirst center is located. There are osmoreceptors to basically detect how salty we've become. High osmolality means more salt, less water. Low osmolality means low salt, more water. Dehydration is the net water loss, meaning we're not taking in as much as we're losing. The premise is if someone has access to clean water and also obeys their thirst, meaning when they feel like they're thirsty, they actually drink, then someone will maintain water balance. The people that you're going to have to worry about most in your clinical practice, infants, lack the ability to concentrate urine, so they have a hard time. Also, they can't go get themselves fluids, right? They rely on their parents. Elderly, this stimulus for thirst declines as people age. They're not trying to be stubborn, they're just not thirsty. My mom lived with us. She didn't like water. She wasn't hungry, she wasn't thirsty, and that's really common in the elderly. You're always gonna be going, hey, did you drink your water today? Here, have some water. They're just not feeling it, and so they tend to dehydrate. People are in a slow state of desiccation anyway as they age, but those are the two groups you're really gonna have to worry about. Also, if somebody is vomiting or has diarrhea, they are losing fluids at a very high rate, and it's hard for them to retain those fluids. So often they'll have, if somebody has severe vomiting, diarrhea, need to give them supportive care and rehydration therapy. So obey your hypothalamus, not. You can also have high hydration. If somebody is overhydrating, then that means their extracellular fluid is going to be diluted, so we'll have a low osmolality. This is going to decrease the release of antidiuretic hormones, so we don't get those aquaporins, so decrease water reabsorption. So someone's going to have high volume, low concentrated urine. You guys know this because when you overhydrate or you're really drinking water, you have a high volume of urine that basically looks like water because it mostly is. So increase urine output, low concentration. Diuresis is the reduction of urine in excess. Just kind of looking at this picture, tying it all together with what we learned from kidneys. You guys already knew about antidiuretic hormones. So when someone is hydrated, then there aren't aquaporins placed in the collecting ducts, so that increases water loss. And that urine is going to be high volume, low specific gravity. If someone is dehydrated and the body wants to conserve water, releases antidiuretic hormone, we get aquaporins in the distal convoluted tubules and collecting ducts, and increase water reabsorption, low volume of urine, concentrated, high specific gravity. There are homeostatic imbalances. If somebody has ADH imbalances, they're gonna have fluid volume imbalances. Syndrome of inappropriate ADH release, they are really holding onto their fluids, so low volume of urine, high concentrated, and we said this fluid has to go somewhere. Our peripheral tissues can swell, but the brain does not swell because it's in a bony case. And so this was more serious than the opposite, which was diabetes insipidus, which means that someone has very low ADH, so they are urinating a whole lot. They don't have that ability to put those aquaporins in, so they have to make sure that they stay rehydrated. So as long as they're conscious and obeying their thirst, it's less serious than syndrome of ADH release. And we discussed diuretics are chemicals that enhance urinary output and water loss. So you can do that by inhibiting ADH, absorption inhibitors, those loop diuretics that prevent the medulla of the kidney from getting salty, which allows us to absorb water, and osmotic diuretics. So diuretics promote diuresis, so urination. Yep, ADH, so antidiuretic hormone, reabsorption of water, and also vasopressin, so pressure on the vessels. So constriction, narrowing that lumen raises blood pressure. Antidiuretic hormone, so antidiuresis urination, so high ADH, that is going to promote low urinary output. The urine that is coming out is going to be low in water, so the solutes will still be there, so it's going to be concentrated. You have a body, think about it when you're not hydrating. You don't urinate a lot, right? And then the urine is darker in color, it's more concentrated. So ADH has to do with water specifically. It targets the kidneys, aquaporins, aqua means water, so pores for water. We're going to reabsorb water.